Hello, a very good morning from Singapore to everybody. Good evening and probably close to night late on the other side of the world. Thank you for joining us this hour. It's my privilege and honor to introduce our guest speaker, the first invited lecture for today, Clinical Professor Natan Zundel. Professor Natan is also the Vice Chair at the Department of Surgery, University of Buffalo. And if I go on to read the seats that he holds for presidents and in various societies, I think I will take 15 minutes, and which I don't want to do. He basically is an integral member of the American College of Surgeons, the American Society of Bariatric Metabolic Surgery, SAGES, IFSO. And he's here as the president of IFSES today to deliver a lecture on new technologies in bariatric and minimally invasive surgery. Professor Natan, over to you.
Thank you very much. First, I want to thank for this kind invitation. I think it's good morning for you guys. For me, it's Friday night, but I'm glad to be here. Hopefully, we will see everybody and we can share together the meeting. I want to thank ELSA for the kind invitation and all the board, and I hope I can be there. This is my disclosures. I hope none of them will be a problem with my presentation. Also, when you talk about new technologies, you need to understand that some of the things I'm going to present are either off-label or they are not ready to use in humans, and I will mention that. Obesity and some other problems are becoming so big that what we have today is not enough, especially when we have the same procedure for more than 35 years, 40 years, 20 years. So people are looking for new technologies, new devices, new procedures, new things to do. So I'm gonna go through them. And this is how technology looks like today. So when somebody look at the technology we have today, it's gonna look like this, yes. We are very resourceful with what we have. We can do what we have to do, but it's not perfect. It's not exactly what we wish for. And when I do new technologies, there are two things that are important for me. This is the first one. You need to make sure it's not fake. You need to make sure that they are not bullshitting you. You need to make sure that what they're telling you is not the promise of la la land, but it's something important. The second principle is this one, is that everybody show you we need to do this, we need to do this. And when you take a closer look, it's technology that we had before. So we are doing the same thing we did 40 years ago. Now we do it in a different way. That is not new. That is recycling, and we need to be aware of that. From surgical point of view, I would say the clip, that is the only thing that it can be a little bit different. So from the surgical point of view, I don't know much to show you because there is not much. SAGES, the other procedure has been around for a while, and they just changed the plumbing. So for me, what is going to change everything probably will be endoscopy. Because if you take a look here from orthopedics, when we have exercise, physical therapy to joint replacement, we have arthroscopy in the middle. When we have cardiology, from exercise, medications, to replace or bypasses of the arteries, we have angioplasty. From obesity, we have the same. For exercise, medications, diet, to the surgeries, we need to have some endoscopy to go there. The third one is more important to me. Safety is very important, but not imaginary safety like this guy thinks that if he drops, he will survive, he will die. We have to be real safety. So the surgery of the future, it's like they will be called nodes, but nodes arrive very early. So now we have different things to do. And I will divide the interventions in two different ones. And I learned with time that every intervention we do in the stomach, it's for weight loss. Every intervention we do in the small bowel is metabolic. So let's go for the stomach one. I don't go much for the balloons because still the same gold standard. Balloon has been around for 40 years. It works better in cosmetic with short time, but it is still okay. Some people promote now that you can have the balloon for a year. We did this study that we published in 2017, that even if the balloon stays longer, even if you put more fluid, the changes in those feelings, it doesn't change much. So I think the same balloon for a short period of time with a short-term goal we do. Probably what it come much better will be this one, that swallowable one that you swallow, it deflates by itself. You don't need to do endoscopy to put it. You don't need endoscopy to remove it. The weight loss will be not as good, but it will be good for the patient. Other one that is causing some commotion in the US is Aspire, where you put a peg, gastrostomy tube, the patients eat, then he puts some fluid to himself, it blended, then with this pump take it out. It's like a controlled bulimia through a gastrostomy. The concept mentally is not accepted for many groups, but the patients are happy, and the weight loss has been close to 50% of excessive weight loss. So I don't do it. I don't think it's gonna stay longer, but it's out there. Suturing probably is the one who has been coming more often. Since we have now very good devices to suture like this one, then it's more about the procedure than the suturing device, because we've been using this suturing device for colovesical fistulas, for duodenal perforation, for ulcers. So now what you do in the stomach is what can change. And we did some study with the Mayo Clinic, for example, with Abu Dhabi, where we showed that we can reduce the volume and we can cause restriction just doing this with the gastroplasty. And as you notice here, there is some fundus there. We thought it's a bad thing, but it's not a bad thing. And we published also 2017 how the suturing patterns change and how we learn now how to do this better. So this is the pattern that most of the people use now. And this is also very important. The weight loss you can attain is very good. Yes, probably it's gonna last for a year, year and a half, 2 years, and it stay good for many patients, but other patients will need an intervention later. But this is what stay in the fundus works. Look at this, retain of food after 240 minutes without the ESG, after the ESG. And that's a very big change. Also, we discovered that we were able to standardize the procedure, like you can see here. So we are doing surgery in 5 different cities, 3 different continents, and it's very similar everywhere. So it can be standardized. And now there are participant centers in the US, as you can see, Mayo Clinic, Cornell, Harvard, Johns Hopkins, and the results are coming next year, and hopefully they will be pretty good. Somebody asked me if we can convert this surgery to another one, and this is some slide that we published together with Galvao and with Mohit Bhandari, that you go back, you see the gastroplasty with the scope inside, you can convert to sleep, making sure that you don't staple the plastic anchors. That will be the only problem, but you can see it with the scope, and as you can see, you have enough space to convert. Dr. Lopez Nava from Spain is working in a different procedure that you can staple the fundus, you can suture the fundus, and they just can reduce the fundus. And now they're doing a new trial in Europe and starting in the US, where they're gonna do the fundus and the body of the stomach with this different suturing device. So a lot of groups are working in suturing the stomach. And this is coming soon. We don't have it yet, but if you take a look to this one, only one suture go around the whole stomach that is being already sucked with suction, and then it will take 10, 15 minutes to do this, and then you collapse the whole stomach. That will make it very, very easy. Let's see how it works. But they published the first result after 6 months, and the results are relatively okay. Let's move to some interventions on the bowel. As I mentioned before, they are more metabolic than weight loss. So when you do stomach, obesity, small bowel, diabetes, and metabolic disease, we learn from bariatric surgery, and this has been published many times, that through surgery, we discovered that we control very well glucose and metabolic problems, preventing the food to be in contact with the mucosa of the duodenum. So a lot of people use different ways to do it, big tubes, like condoms, preventing the food to be there. And as long as you have that prevention, the control of glucose is pretty good, like we have with the endobarrier. The studies were stopped in the US because there were a lot of complications with abscess, hepatic abscesses, but the concept's still there. And there are some groups that keep working in the same. This, for example, from Dr. Rakesh Karpala, Metamodics, Asian Institute. So they do the same concept, but with a better fixation. So you don't have the ulcers, you don't have the bleeding, and that will prevent probably the hepatic abscesses. Also, we know that that mucosa will come back. So we're looking for something safer to ablate that mucosa. When it comes back, we can ablate it again. And this is what is DMR. DMR, what they do, this is the first studies that they were done in Brazil. With boiling water, you lift the mucosa, you introduce this catheter, with boiling water, you necrose the mucosa, and then it will fall. And then, as you can see, 1 year follow-up, it comes back. It will come back, so it's totally reversible. Yes, you can have some strictures, and that's one of the complications that can be a problem. You need to understand that, but you can dilate. But look what happened when you do that. This is the Revita study 2. Look what happened with hemoglobin A1C after 12 weeks. Look what happened with HOMA IR. So the reduction is very significant, but when the mucosa come back, the glucose come back. So that's where you have to be careful, and you cannot be burned every 2 days. So, but look at the effects in the fatty liver. Look at this. When you take a look to the MRI, everything that is yellow is more fat. After only 2 weeks with the procedure, most of the fat of the liver is gone, and that will help us to control the metabolic problem. Can I burn the mucosa every day? No, but there are other ways to do it? Yes, and the best way to do it is with lasers. So there is a group in Israel, what they're doing is they mark the papilla, you know, like the drones shooting with laser from space. This is the same thing. They shoot with laser the submucosa, so they burn the whole submucosa, and you can do it as often as you can. The result is not as good at removing the whole mucosa, but this is much safer. So we'll see how it goes in the future. And now we have Lucy. Lucy is a pill that has been designed in Harvard. It's not available yet. It's luminal coating. You take the pill, it will coat the whole duodenum. Food cannot go there. Then it stays for 6-8 hours, and then you can take another pill. So this will replace pills like metmorphin, another one. So you will have a pill that prevents food to eat, and then glucose will be controlled with coating the duodenum in the future. This one is already approved in the US, the same concept, glycine, and then when you mix it with mucin from the stomach, it creates that protective barrier layer, and you have 60 to 70% of reduction in glucose. What about when you have the, as you see in the ASMBS, we increased to 16% revisions, most of them through bypasses now and sleeve. So what do you do with them? The surgeon thinks with the heart and the brain, they think every surgeon treat a surgery complication where we get with another surgery. I don't think so. If you have a big anastomosis, you can use argon beam coagulator. You can suture it and you reduce the anastomosis. We also published this in 2017, how you can decrease weight just suturing the anastomosis. But what if you suture and you can put a stent like this one, 5 millimeters outside, 1.5 millimeters inside, and then you create a new anastomosis, and this is the concept. You reduce the size of the pouch, you put this tube that will reduce the size of the anastomosis, and then you have also that prevention of going to the same 60 centimeters. That is coming. What about this one, magnets? What you have here is 2 magnets that they will couple, and they will create anastomosis. So you do this with endoscopy and fluoroscopy, and then they connect. You put one through colonoscopy, one through the endoscopy, or you can do it by laparoscopy. And without bleeding, without leaks, they open by the day 4, and they stay open for a long time. And as you can see in this video, you can deploy it very easily, like you can see here. They are orthogonal. After they open, after necrosis, they will communicate. And now we move it with the magnets. We've been using magnets from other stuff. We've been using magnets to present the liver, to present the gallbladder, and you can move it, the magnets, any way you want. Now what we're doing is by laparoscopy, and this is our next move, we'll be able to move those magnets, and we can do any anastomosis in the small bowel, in the colon, with laparoscopy combined. For lastly, endorobotic, I think will be much, much better than robotics. There are many platforms. They are very easy to move. They are very easy to handle. They are very similar to the robots in the movement, but their angulation, their tips are much, much better and different. As you can see here, you can have very fine movements. They don't triangulate like surgery, and this has been a concern by surgeons, but I don't think you need to triangulate like surgery when you're working in the colon or the stomach of the esophagus. This is more than enough if the strength will be good for needles and things like that. Look, for example, here, we're doing here a dissection in the colon. Remember, some of the resection in the colon, they are concerned that you go through all the layers. With this, if you want, you can go through all the layers, because guess what? When you finish to remove, you will be able to suture like you are suturing in surgery. So if I go all the layers, with this suturing inside the colon through the robot, you will be able to suture whatever you want. So I think endorobotics will be the real things that is gonna change how we do endoluminal surgery. So in conclusion, Mr. Chairman, so the first thing is primum non nocere, so kill as few patients as possible. You don't need to be the first one. You don't need to try in humans if it doesn't go to a big trial. Second, sorry, this is in Spanish, but it says, shit, I'm Batman. So the little dog thinks it's Batman. Endoscopy and these devices, you cannot compare with scopinaro surgeries. You cannot compare with bypasses. But you can say that they are minimally invasive. You can intervene every 2, 3, 4 years if necessary. And some patients, they don't need any other intervention. So this will be safer. The last question, who's gonna be doing this? Bariatric surgeons or GIs? And this is my answer. Whoever does it better. I don't care if the GI, the surgeon, whoever does this better is the person who should be doing it. With this, we reach much more people in need, even if remissions of diabetic, metabolic, and weight loss are temporary, and they will need new reinterventions that we can still do like this. Thank you very much, and I again very honored to be presenting here tonight.
Thank you very much, Professor Natan. And thank you for that really interesting lecture as usual. And we look forward to you in other sessions. Thank you, everybody, and let's go to the breakout rooms now.
Thank you very much.
Thank you.